I'm a physician and a scientist, and my entire professional career has been guided by the core principles of science. But as many of you know and understand, we scientists like order, precision, hard evidence and data, and established procedures. This is particularly important when we're dealing in the process of implementing a clinical trial to determine the efficacy, and in many cases, the safety, of an experimental intervention such as a vaccine or a therapeutic. We stick to strict clinical protocols and strict regulatory protocols. That's the best way to do clinical research. That's the only way to do clinical research. Or is it? True, there are certain core scientific principles that must remain sacrosanct and inviolate. But what I want to talk to you about today is the importance of flexibility in dealing with a situation where people appear to be challenging your core scientific principles, but in fact are not. They're questioning the sometimes undue rigidity that is associated with the implementation of those core principles. I came face to face with that 3 decades ago, and it has greatly influenced the way I today respond to and react to people who question what I do as a physician and a scientist. Let me explain. The year was 1984. I was then, as I am now, the director of the National Institute of Allergy and Infectious Diseases at the NIH outside of Washington, D.C. A terrible plague had descended upon the community, particularly the gay community, in the form of HIV/AIDS. In addition to being the director of the institute responsible for the design, implementation, and funding of infectious disease research, including HIV/AIDS, I was a physician and am a physician, and together with my colleagues, we were taking care of hundreds and hundreds of desperately ill AIDS patients. This was a time when there was no therapy, and despite our best efforts, the prognosis was dreadful. If a person came into us with advanced disease, their life expectancy was measured in several months to a year and a half. I was trained as a healer, and I was healing no one. This was unquestionably the darkest period of my professional career and, in fact, my life. And as the situation spiraled, there was a rush to screen drugs, develop drugs, put them into the clinical trial process and the regulatory process to get them approved. But the system for that, controlled almost exclusively by the federal government, we found out was too rigid. It was ill-suited to the emergency nature of what was going on in the trenches. Let me explain. I just said that the prognosis was months to a year and a half, and our time-honored processes took several years at best. And so as the frustration mounted, an activist movement emerged, predominantly in the form of young gay men who wanted a say into what we were doing that directly impacted their lives. They wanted more flexibility in the clinical trial process. They wanted better access. They wanted more flexibility in the regulatory process. But the scientific community instinctively rejected that because conventional wisdom is that they weren't scientists, so they did not know. So they became very provocative and challenged us. And the more they did, the more the scientific community withdrew and listened less. So they became very iconoclastic. They came onto our campuses and our facilities with dramatic theatrical costumes, blowing whistles, setting off smoke bombs, disrupting our function. They wanted to be heard, but no one was listening to them. In fact, they were being pushed back because of that. Now, I, for one, as an established scientist who felt the rules of the game were very important, at first was not prone to listen to what they had to say. However, gradually, over a period of weeks to months, and I'm not exactly sure what it was, but when I reflect, I think it was looking at the frustration, the anger, but the real underlying fear and terror for their lives that got me to start getting beyond the dramatic, confrontational, and theatrical tactics and start to listen to what they were saying. And what they were saying was starting to make sense to me. And I wanted to hear more. I got my chance pretty quickly in one of the several demonstrations on the NIH campus. When they were disrupting our function, the police were getting ready to arrest a bunch of them. And I was looking out the window of my office onto the bucolic NIH campus with these smoke bombs going off. And as they were getting to get arrested, I said to myself, how can we be arresting people for wanting to save their lives? It was clear that something had to give, and at that moment, that something had to be me. So to the great consternation and fierce objection of my own staff and my scientific colleagues throughout the country, as I heard later on, I asked the police not to arrest them, but to bring several of the leaders up to my office to begin the first dialogue with them. They were stunned. One of the activists told me that was the first time any government official had ever even spoken to them, much less engaged in a dialogue. Now, I can't tell you that meeting, that first meeting, made a major change, but it began a process that extended over years to decades, where we started listening to each other. I wanted to take it even further because we were talking in my office. I wanted to go out to their turf. So what I decided to do was to go alone to the Gay and Lesbian Community Center in the middle of Greenwich Village to participate in one of their town hall meetings, to, on their own territory, to hear what was going on. And it was so clear that in that room, the frustration of not being heard and not being part of the process, and the fear and the terror, I said to myself, if I were in their shoes, I would be doing exactly the same thing as they were doing. And so I still wanted to take it further. I had, over the previous months, developed a friendship with the late and now iconic founding director of Project Inform in San Francisco, Marty Delaney. Marty invited me to San Francisco and brought me to the apartment in the middle of the Castro district of a young man, a gay man with advanced AIDS who was being taken care of by his partner. Just at that time, we at NIH and the FDA were putting together a protocol to determine the safety and efficacy of an experimental, potentially toxic drug called ganciclovir, which is a drug against cytomegalovirus, which was one of the complicating infections that HIV-infected individuals got. It was terrible because it had one of the effects of making people blind because it attacked the retina. Now, the rules of the game, the strict protocol, said that, in fact, you could be on ganciclovir in the protocol, but you couldn't be on any other drug. Now, the situation was, unfortunately, that most of the people who needed this drug were HIV-infected and were likely on AZT, which was the only drug that was available. But the protocol said one or the other. I'll never forget the look on that young man's eyes as he gazed up at me from his bed with his already damaged eyes and said, "Dr. Fauci, don't you folks in Washington get it? I'm HIV-infected, and my life is being prolonged with AZT. I also have cytomegalovirus, and I'm going blind. You're telling me I could be on one drug or the other. What kind of choice is that? I can either go blind or die. Well, that did it for me. All of a sudden, the time-honored rules and regulations that I had gone by didn't make any sense to me. And so, what we did with the activists in New York and San Francisco, we put together something called a parallel track, where you do a strict protocol according to the rules at the same time that in parallel, what you do is allow a major access and accessibility to the drug on an experimental basis with informed consent. One of the activists told me after that, it's good that you did not give in to us or give up to us. You brought us in one direction, we brought you in the other. You were not always right, nor were we. Now, over a period of years to decades, we didn't always get along, but wonderful things happened as we talked to each other. We had in the mid-90s the development of drugs which, when used in combination, completely transformed the HIV terrain, because instead of having a life expectancy of months to a year and a half, with the combination of drugs, individuals who were 20 years old and infected, you put them on a drug, they would have a life expectancy of more than 50 years into their 70s, a very important accomplishment. That was terrific for the developed world, but there was something wrong with that. Which brings me to another example of how conventional wisdom got it wrong and flexibility got it right. Let me explain. 67% of all infections with HIV are in southern Africa. And yet, in the late 90s and early 2000s, there was no accessibility to drugs. So they were dying despite the fact that drugs were available. The conventional wisdom said, and by conventional wisdom, I mean people in the developed world, that giving the logistic, the cultural, the structural issues in Africa with a poor healthcare delivery system, that you could not get a situation where people would be taking drugs every day for the rest of their lives. But the Africans disagreed. They said, give us the resources, help us to be trained, and we can do it. Very few people were listening. Luckily, in 2002, President George W. Bush sent me to Southern Africa on a fact-finding mission to determine the feasibility of a transforming plan that would actually bring treatment and prevention to Southern Africa in a way that was effective and accountable. So I went to Africa and visited several of the countries that I had already visited before, and my African colleagues told me the same thing. Give us the opportunity, and we will make it work. You know, I felt like I was back in the 1980s in the Gay and Lesbian Community Center in Greenwich Village or in the Castro District. These were smart people who were defying the conventional wisdom, who wanted to be able to have the opportunity to make something work. So I came back to the United States and I told the president that in fact we can do this if we give them the resources. So he told me to put together over a period of several months, which turned out to be a program called the President's Emergency Plan for AIDS Relief, or PEPFAR, which over the past 12 to 13 years has prevented millions of infections and saved millions of lives. So once again, conventional wisdom got it wrong and flexibility got it right. Now I tell you all of this since sometime you may, in medicine, in science, and in public health, be questioned or confronted with people who don't agree with the way you're doing things. This may be particularly relevant in the age of the internet, where a lot of medical information is a mouse click away. And so I hope that my journey through AIDS activism will have you pause and listen instead of instinctively rejecting, and think about the possibility of some flexibility. Because the activists in the United States and in Africa while not violating core scientific principles, did challenge conventional wisdom, and what we came to was a delicate balance between adhering to the fundamental principles of science, even with some rigidity, at the same time that we had the flexibility to make things work in the real world. And what has resulted was a vast improvement in a process that has led to an alleviation of suffering and the saving of millions of lives in one of the first pandemics to afflict mankind. Thank you.